Recorded. Okay. All right. So you have already covered, we did the intro. I finished that yesterday with the compartment syndrome. And you've done back and neck, yes? Have you also done upper extremity disorders? No. Okay. That's going to be Professor Geary, and that will come. So we're going to do lower extremity disorders today, and we'll finish that up today. So we're going to talk about the hip, the pelvis, the knee, the ankle, and the foot. Basically, this is just one long lecture, so we'll go as far as we can and then pick it up this afternoon. We want to review a little bit of the biomechanics, obviously just as a review. I'm not going into it in any great detail. We want to talk about some of the common symptoms of lower extremity dysfunction. And also, we want to talk about some hip fractures. Hip fractures are a common problem in the elderly, much more common in women than men due to osteoporosis. Maybe later on, 10 years from now or 15 years from now, we'll start seeing less hip fractures because now we have medications to treat osteoporosis, whereas when these people who are getting fractured now, 20 or 25 years ago, or 30 years ago, there was no such medications available. So when people got osteoporotic, they just got osteoporotic. So hopefully we'll see a decrease in the number of individuals who develop osteoporosis and then subsequently get fractures. It is a big drag on our healthcare system because these patients obviously need to be hospitalized, they need rehabilitation, they get surgery, they get expensive hardware, so all of this costs money. And then we want to talk about osteoarthritis again because it's a common problem that we see, particularly in the hip and the knee. We tend to see a lot more osteoarthritis in the hip and the knee than we see in the shoulder, say as a large ball and socket joint. Why do you think, and even if you don't know this, just think about it for a moment. Why do you think we see so much more osteoarthritis in the knee and the hip than we do in the shoulder? Somebody said more use. I heard that. Not necessarily true. That's it. Somebody said weight-bearing joint. That's the big difference. The hip and the knee are weight-bearing joints and therefore more prone to the wear and tear, whereas the shoulder is a non-weight-bearing joint and so less prone to the wear and tear. So the hip and the shoulder is a ball and socket joint. But in the case of the hip, the ball has much greater coverage through the socket portion. And the ball is the head of the femur, or the femoral head, and the socket is the acetabulum. The acetabulum rises off the pelvis. So because there's greater coverage in the of the ball in the hip, there's a tendency to have much less dislocations of the hip. So we don't tend to see as many dislocations of the hip as we do the shoulder. However, there's a compromise there. The shoulder is a much more mobile joint than the hip. And the reason for that is because the shoulder is less stable. And because of that decrease in stability, there is this increase in mobility. So the shoulder is very mobile and less stable. The hip is much more stable, but more immobile. So the hemipelvis is formed by the pubis, the ischium, and the ilium. Those are basically the bones that make up the pelvis. There are two of each on either side, and the pelvic girdle is fixed to the body through the lumbosacral junction, And again, this relationship can lead to hip problems, sometimes resulting in back problems. So somebody gets a hip problem, they alter their gait in order to reduce their pain when they're in motion. And as a result of that, because of the intimate relationship between the hip and the sacrum, patients can wind up with lower back problems as well as hip problems. The pelvic ring, basically formed by the ilium, and the junction of each pubis forms the symphysis pubis, which is actually considered a joint because there's a cartilaginous material between the two pubis bones. Basically, this is a strong and stable ring. Now, the one thing you should be aware of with a ring, any ring in the body, whether we're talking about the pelvis or in some ways the fibula and the tibia create a kind of ring. When you break a ring, I mean, if you had a pretzel ring, let's say, and I challenged you and said, I want you to break this pretzel ring, but you can only break it in one place. You can't break it in two places. If you break it in two places, you lose. I win. And I would say that it's virtually impossible for you to break that pretzel ring and have it still be stable, broken only in one place. The ring will break in two places and you'll have two separate pieces. That's what's going to happen every time. And the same thing happens in the pelvis. So if you see a fracture in the pelvis and you see it and you say, okay, there's a fracture of the pelvis, and it's in the ring of the pelvis, in the ring of the pelvis, I guarantee you there is another fracture somewhere else in that ring, so look a little harder, okay? Because you will not see one fracture in the pelvic ring. And the same way we have a fracture, if you see a tibial fracture in the distal tibia down near the ankle, it's easily missed, but there's going to be a fracture of the fibula proximally up at the knee. That fracture can be easily missed because the patient is complaining mostly of the problem at the ankle. You believe the ankle is fractured, you get an x-ray of the ankle, and the x-ray does not include much of the fibula proximally, so you never see the fracture. So anytime you see a fractured tibia, you always order one AP view of the knee, which will bring out the fibula fracture that will be present because, again, that ring needs to break in two places. And so that is actually called a Maisonneuve fracture, nice French name, and it's a known entity in orthopedics. So if you're an orthopedist and you see a fractured tibia distally, you always get that other x-ray if the other person didn't order it. But if you're in the ER and you see that sort of a thing, make sure you order the knee. AP view of the knee will show you the proximal fibula fracture. It's really just a curiosity because you don't really have to treat that fracture. Once you align the tibial fracture, the other fibula fracture comes into alignment as well. And there's not much weight bearing that occurs in the fibula, at least not proximally. Most of the weight bearing is in the tibia, so you don't need to worry about that. Okay, so there is a fibrocartilaginous rim around the acetabulum, same as in the shoulder. It's called a labrum. It allows a little additional stability in the joint without compromising the mobility. Again, you have it in the shoulder, you also have it in the hip, and occasionally people will get, like Alex Rodriguez, the baseball player, a labral tear, and much more common in the shoulder than in the hip, but it can cause the same problems in the hip that it does in the shoulder, a feeling of instability on the part of the patient, and pain. So there's a lot of ligamentous attachments to the hip. Since it's not as mobile, nature has provided more ligamentous and very strong ligamentous attachments. So again, preventing the hip from dislocating. The femoral head is the ball, and the acetabulum is the socket. The angle of the femoral shaft, or the femoral neck, is 135 degrees. So when we have to do a hip replacement, or a patient has a fracture, like an intertrochanteric fracture that we would treat with a plate and screws, the angle of those pieces of hardware is, as you might guess, 135 degrees. Okay, so this is basically what the hip looks like. Again, this is the pelvis. So this is the ring that I was referring to. So if you saw a fracture here, there has to be a fracture somewhere else in the ring. So you would need to look anywhere else in the ring to see the fracture. This is the lumbosacral, sacroiliac joint. So your sacrum is here, the ilium is here, and this forms a joint. This is a common area for elderly people to complain of lower back pain, and it's easily misdiagnosed as being maybe something in the discs or spinal stenosis. The hallmark of this pain is it's localized to the lower back. The pain does not go down the leg as it might with a nerve root or radiculopathy pain. If you palpate over the problematic sacroiliac joint or SI joint, you will elicit tenderness, and the patient will identify that tenderness as the pain that they've come to see you about. The good news here is a steroid injection done in radiology by the radiologist under fluoroscopic control will result in 6 months to a year of relief for the patient, and then the injection can be repeated. The downside of missing this is a whole big workup and treatments for lumbar or lumbosacral back pain or spinal stenosis that, of course, are not going to be effective because you're treating a problem the patient doesn't have. So you wind up getting MRIs and all these other things, and the patient just doesn't respond to treatment. So anyway, here's the hip joint. They even show you a little bit what the labrum looks like, I think. No, probably that's not the labrum. That's the femoral head portion of the head. This is the femoral neck. This is the greater trochanter. You can see there's not a lot of tissue out here. This is that area for men just behind the pocket on your pants, bony prominence. Ladies, you have a little more padding here, a little harder to feel, but this is the area where people get trochanteric bursitis. Again, sometimes mistaken for osteoarthritis of the hip. The difference here is osteoarthritis of the hip will give patients pain in the groin and pain that radiates down the anterior thigh, sometimes to the knee, and sometimes the patient will even misinterpret the pain as originating from the knee. Whereas the trochanteric bursitis, the pain is out here. This is the area that's bothersome. The difference here again is if you ask the patient to point to their pain, if they have osteoarthritis of the hip, they'll point here. If they have trochanteric bursitis, they'll point here. When you palpate out here, you'll reproduce their pain. A steroid injection out here will give the patient relief. And again, the thing that tends to mislead people is this is often found in older people, and then you do an x-ray of the hip, and guess what? You find some osteoarthritis because they're old and they have some osteoarthritis. But their complaints of pain may be out of proportion to the amount of arthritis you're seeing. And even if you're seeing a lot of arthritis, if the problem of their pain is out here, treating here is not going to result in relief. Okay? And this is the angle that's 135 degrees right here. So any hardware that we put into the hip, if it's a hip replacement, it's going to have an angle to it of 135. If it's a plate and screws, the plate will go along here. Oops. The plate will go along here, and the big pressure screw through the area of the fracture will come at 135 degrees out here. Okay? This is the lesser trochanter. Okay, so greater trochanter, lesser trochanter. Okay? All right, so this is just an x-ray of the same. Again, here's the lumbosacral joint. Here's the, I'm sorry, I keep calling it lumbosacral. Here's the sacroiliac joint, the SI joint. Here's the other SI joint. And even in this patient, you can see this one looks a little bit more open. This one looks a little bit more closed, and that would be what you would see in a patient who has degenerative disease. So the joint would be a little less pronounced. Again, here is the hips. Why do we see a little bit more sclerotic bone here and a little bit more sclerotic bone here? Anybody want to take a guess as to why the bone is a little more sclerotic here, less so? And when I say sclerotic, I'm looking at this whiteness. See the whiteness? And there's also whiteness here. But when we look down here, it's not so white, it's more gray. Same thing here, whiteness, less whiteness, whiteness, less whiteness. Anybody want to take a stab at why we see that sclerotic bone? What is sclerotic bone? Is it less or more dense? More dense. Okay, why would it be more dense here? What makes a bone more dense? Stress. Stress can come in different forms. What's one form of stress on a bone? Weight bearing. Okay. See, you figured it out. You knew it. You just didn't know the right questions to ask yourself. That's exactly it. The main plane of the weight bearing in this joint comes right through here. It doesn't come through here. It comes through here. So as a result, this area of the bone and this area of the bone become more sclerotic with time, over a lifetime, and that's the rationale. This is the weight-bearing plane of the hip. Okay, it's supporting the upper torso, and that's where the weight is coming through. Okay, this is not a fracture. Okay, just a mere, little defect, as it were, in the bone, or sort of that junction between the sclerotic area and the less sclerotic area. When you're looking for arthritis in a joint, you look at the joint space. This area here represents cartilage, articular cartilage. It's invisible on an x-ray. So what we tend to see is we see the bone seemingly end here and the bone seemingly end here, and nothing that we can see in between. That's the cartilage. The more the cartilage wears out, the narrower the space gets, until finally the two bones are kissing one another, as it were, and that represents end-stage arthritis, when what we say in the terminology is the joint space has collapsed, and one bone is now on the other bone. There's very little or no cartilage between the bones, and the result is pain, stiffness, crepitus, in other words, crunching and grinding in the joint, and loss of mobility. And that's how patients present with osteoarthritis. Here's the symphysis pubis. Again, cartilage in here, in between the bones. Just like there's cartilage here and there's cartilage here, everywhere a bone meets another bone there's cartilage. Okay, so the sciatic nerve emerges from the sacral plexus and through the sciatic notch posteriorly, and so at that point this nerve is vulnerable to pelvic fractures. If a patient has a fracture of the pelvis, you need to inquire as to whether or not the patient is having any symptoms suggestive of radiculopathy from the sciatic nerve. So you would ask about pain going down the leg, either lateral, posterolateral, or posteriorly, any numbness or tingling in a similar distribution. The femoral artery, vein, and nerve are also well protected by muscles, so they are less likely to be injured by a pelvic fracture or a hip dislocation. Nowadays, you're hearing a lot about the less invasive approach to hip replacement surgery. The classic approach has always been posteriorly, The reason that the posterior approach was favored was because there were less vital structures that were between the surgeon or the skin and the hip joint when you go in posteriorly. When you go in anteriorly, you're cutting through the groin area, and you have the femoral artery and the femoral nerve, which are major structures, and the potential is for injury because those structures are between you and getting down to the joint. So now they've developed approaches, and they've developed equipment that allows a safer approach. The result for the patient is a smaller incision, less manipulation of the muscles, and as a result of that, less postoperative pain. Less postoperative pain and a smaller operation means the patients can be get back to activity much more quickly. So hip fractures are a big drain on the healthcare system, and nearly half of all hospital-related costs for fractures, not all hospital-related costs, but for fractures, are spent on hip fractures. Why? Every patient who gets a hip fracture is admitted to the hospital, and just about everyone is going to get an operation. All the other fractures, patients don't necessarily have to be admitted to the hospital. You can either do a closed reduction and put them in a cast and send them home, or you can, maybe do surgery if they need a plate and screws, but they can be home in 24 to 36 hours. So hip fractures account for 3.5 million hospital days a year. So obviously, if we could reduce the number of hip fractures, we could reduce our cost for medical care, and if we can reduce our cost for medical care, all of our premiums would go down. So bottom line is, if you're taking care of elderly patients in your primary care settings, work them up or evaluate them for osteoporosis, particularly your female patients, but it can happen to male patients too. This is now a disease that we can treat, and if you monitor your patients when they go from that osteopenic point to the osteoporotic point, you can initiate treatment. Hip fractures also carry a 30% mortality within 1 year of the injury. Now, I'm talking about mortality here, not morbidity. Morbidity are complications. So you have a surgery, you have a pulmonary embolus following your surgery, you're put on anticoagulants, you survive, that's morbidity. You have surgery, you have a pulmonary embolus, post-surgery, you succumb to your pulmonary embolus and die, that's mortality, okay? So what we're saying here is 3 out of every 10 patients who has surgery for a hip fracture is dead within 1 year of their surgery. Now, in every case, is the cause related to the surgery? Maybe not, but who knows? Because surgery in an elderly population creates great stresses, and some of these stresses could lead to problems that develop, a month, 2 months, 6 months after the surgery. But that's the way they track this. Now, surgical mortality and morbidity is tracked in 30 days. So if you have a surgery and you have a complication on day 29, it's considered a post-op surgical complication. So if you have a hip fracture or, you have, you have hernia surgery, and 29 days after your surgery you have a myocardial infarction, it's considered a post-operative complication. Again, is there a relationship or not? Who knows? But it's still considered as such. Joe, did you have a question?
Not anymore.
Not anymore. Yes.
Are you talking about the pelvis or the proximal feet?
I'm talking about the hip fracture, not the pelvic fracture.
So you're talking
Right. The big difference between pelvic fractures and hip fractures, the vast majority of pelvic fractures are non-surgical. So the patients are not subjected to surgery, and therefore the risk of complications is much more reduced. Now, that's not the case in every pelvic fracture. I mean, jump off a building and shatter your pelvis and you're going to get surgery. But the vast majority of pelvic fractures, again, that we tend to see in the elderly population due to osteoporosis, occur because a person falls and they fracture their pelvis. And it's painful, you put them in bed for about 24 hours maybe, and then you try to get them up just as fast as you can. Because, again, mobilization and, or I should say immobilization and complications go hand in hand. And a lot of these complications arise simply because the patient is post-op, you can't get them out of bed as quickly as you like, and bad things happen to elderly people when they become inactive. They can get infections, they can get, when I speak of infections now, they can get urinary tract infections, they have a Foley catheter, that becomes the root of infection. Their immune system is compromised, so their Foley catheter infection or their bladder infection becomes sepsis, and they succumb to the sepsis. Or they get a PE, or a DVT leading to a PE, and they succumb to that, or they have an MI, they have a stroke. Lots of bad things can happen. Again, falls in the elderly is the major cause of hip fractures and the osteoporosis, and the fractures fall into four basic categories. Subcapital fracture is just below the femoral neck. The femoral neck fracture is at the femoral neck. The intertrochanteric fracture is between the lesser and greater trochanters, and the subtrochanteric fracture is below the greater trochanter. So those are the four basic hip fractures, and if you look at an x-ray of a hip fracture, it's going to fall into one of these four categories. They're not all treated the same. They're all treated with surgery, but they're not all necessarily treated the same. For instance, the subcapital fracture, the femoral neck fracture, is often treated with like a half of a hip replacement. So basically, it's just a ball and socket that's put in all on the femur side, and then that fits into the patient's own acetabulum. It's a bigger operation than some of these other ones, but you can't put a plate and screw through a fracture that's going right through the femoral neck. It's not going to work. The intertrochanteric fractures lend themselves very nicely to a plate and screws. Sometimes a femoral neck fracture is impacted. So in other words, the two fracture fragments are driven into one another. There's not a loss in the length of the leg, but the fact that these two parts of the fracture were driven into one another makes for a much more stable fracture. As a result of that, sometimes these fractures can be just treated with two pins going right through the area of the fracture from the femur end into the femoral head. So right through the fracture, through that neck. And the nice thing about that surgery is it's done cutaneously. So what do I mean by that? I mean you make a tiny incision, you make two tiny incisions, one for each pin, and then you just drive the pin in with a drill right through the little incision you made, and then you cut the pin off. So it's a very simple surgery. It doesn't take very long, subjects the patient to much less general anesthesia, a much smaller operation because you're not cutting through all this various tissues and muscles and everything. And as a result, the patients recover much more quickly with less risk of complications. The blood supply to the femoral head comes up through the femoral neck. So fractures that are proximal to the femoral neck can interrupt the blood supply, cause avascular necrosis. So sometimes these fractures, when we look at them, we just say, you know what, the risk of avascular necrosis and subsequent collapse of the femoral head is too great, and we're just going to do a hip replacement. That, of course, is the biggest surgery that we'd have to do in relation to a hip fracture, but in some cases, it's better to just do that surgery right away than do an ORIF, an open reduction internal fixation, that ultimately is doomed to fail. And then you have to do the hip replacement. So just do the hip replacement and don't put the patient at risk. The other time that we'll do a hip replacement with just a fracture is if we look at the hip joint and we see that it's got a lot of arthritis in it. Again, the patient is not going to do well when you try to mobilize them and get them up moving around when they have the added problem of a repaired fracture with a pre-existing significant osteoarthritis. So again, in those cases, it's best to just go ahead and do the hip replacement at the time of the injury, even though, again, you're subjecting the patient to more surgery, but you're less likely to have to subject them to a second surgery further down the line and a bad result. So how do patients present when you see them in the emergency room with a hip fracture? Basically, in about 5 words, fall down, go boom. That's basically how they present. So there'll be a fall, the patient will have an injury. The classic presentation for a hip fracture is that once the patient falls and someone comes to their aid and gets them up, they're unable to weight bear on the affected leg. Okay? So when you see somebody who's elderly or not even elderly, you see somebody who fell, they landed on their backside or they landed on their side, and they're not able to weight bear post-injury, look for a fractured hip. Occasionally, you will see patients with a fractured hip who present complaining only of knee pain. That's it, just knee pain. And because the injury is relatively acute, you may not see any contusion over the hip to give you a clue that the patient's real problem is up at the hip. Of course, you evaluate the knee, you examine the knee. The patient complains of some pain as you're moving the leg around, and you get an x-ray of the knee, and the x-ray of the knee is negative. Then you say, well, I guess there's no fracture. You probably just bruised your knee badly. And again, you try to get the patient up, and you can't do it. So you lay them back down. At that point, you get an x-ray of the hip. And again, the rationale here is sometimes patients can just have knee pain with an injury to the hip, and it's an occult injury, and it can be missed. But the clue would be, again, the patient is unable to weight bear with a normal knee x-ray. Why was the patient complaining of pain when you examine their knee? Because when you examine their knee, invariably you're going to flex their hip. And when you flex their hip, that's when you get the pain. So you go back to the patient and you start to move the hip around without moving the knee. So you keep the leg straight and you move the hip this way and you move the hip that way. And guess what? You reproduce their knee pain when you move their hip around without bending their knee. That's the other tip-off on physical exam, that this is a hip problem and not a knee problem. Okay? So again, go with the money, as they say, right? If it's an old person and they fell and you can't really come up with any pathology in their knee, despite the fact that they're complaining vigorously of knee pain, then look to the joint above, which is the hip. Most of the time, the classic position that these patients will be is they'll be lying on their back. The leg will be externally rotated, so that means that the leg is, like if this is my knee, my leg is out this way because the hip is externally rotated and the affected leg is shortened. So if you bring the 2 legs out, if you stand at the foot of the stretcher and you bring the 2 legs out so that the feet are, both at the same position and the legs fully extended, you'll discover that the affected leg is a little bit shorter than the other leg. And that's, again, because when the bones slip out of position, it makes the leg get shorter. So, that's the classic position. So, again, occasionally, and I've seen this a few times, but the one time that I saw it that was most impressive to me because of the circumstances was an impacted femoral neck fracture. Again, talking before about that impacted fracture where one bone is driven into the other, that is relatively stable, and as a result, the patient is able to weight bear. My boss was away on vacation. I was still seeing patients in the office. It's a solo practice, so nobody was around, but there's another orthopedist in the community that was my alternate supervisory physician. I didn't see any patients in the emergency room for obvious reasons, but I still saw patients in the office, either new patients or follow-up patients. So a woman had called and basically said that she had knee pain and she fell and she wanted to be seen. So they brought her into the office, and of course, as soon as she came in, they got an x-ray of her knee, and I evaluated her, and I wasn't overly impressed with her knee, and her x-ray of her knee was negative. But I did notice that she had some pain as I moved her leg around, and I said, I better just be on the safe side and get an x-ray of the hip, and that's what I did. And the x-ray of the hip showed an impacted femoral neck fracture. And that's why she was able to weight bear, because it was a relatively stable fracture. So I called my alternate supervisory physician, who was quite surprised when I told him I had a patient in my office with a hip fracture. And he said, what? And his first reaction was, I thought you're not seeing patients in the ER. I said, I'm not in the ER, I'm in my office. And I told him the story, and he said, okay, fine, send her over to the hospital, and I'll admit her and do the surgery. And of course, when my boss came back, he was pretty, he wasn't angry at me, obviously. He was upset, because this was one of those 2 pins, you go home like 24 hours later, it's easy surgery, and it would have been another case for him, but, what can you do? I said, if you're going to go off to the Caribbean and play, you got to expect something that's going to happen like this. So, okay, so the x-rays are going to confirm your diagnosis. So this is what the patient looks like. Again, you can't really fully appreciate it here, but if you look carefully, you can see that this leg looks like it's just coming down a little further on the stretcher than this leg is. And again, externally rotated and a little shorter, and that's the clue that this patient has a fractured hip. And again, sometimes these fractures can be very subtle. I mean, you could take a quick look at this x-ray and easily miss this fracture. And I can tell you that when you get the x-rays back from radiology, they don't come with arrows on them. Okay? So, but here's the fracture right here. And it's an impacted fracture, and that's why this line is white. Usually when patients have fractures, you see gray or black, because you see a space where the bone normally would be attached. So again, this would be an easy fracture to miss. And again, the patient might be weight bearing. So again, this is a subtrochanteric fracture of the hip. This is not such an easy fracture to miss. The first thing that should catch your eye is, remember we talked about a 135-degree angle, and we look at the femoral head, and then we move along the femoral neck, and the first thing we notice is the femoral neck looks like it's parallel to the ground. That angle should be like this, and then we go out here, and all of a sudden the femur seems to end right here. Where is the femur? Well, here it is down here. Here's a piece of it, and here's some of it, and then some of it's going up here and here and here. And of course, this piece is supposed to be turned about 90 degrees and attached here. So the way you would operate on this is you would attach a little pulley device to the patient's foot. And they're on the table, they're already anesthetized, they're asleep. And when you attach the little thing to their foot, the little thing that wraps around their foot, you start to crank. And as you crank it, you pull this bone out. And as you pull this bone out, this bone will flip back into its regular position. And you might have to crank back the other way if you see that the pieces are too far apart, too distracted. So you crank back the other way and they come closer together. When you get an alignment that's appropriate, then you do your surgery and you put in your plate and screws. Okay? Oh, come on. So this is an intertrochanteric hip fracture. And again, this is not necessarily, well, this is some pins. So in this case, 3 pins that have been put in. The surgeon decided that the pins would hold this fracture well. But you can see the fracture line right here. The arrow is following the fracture line. And why do we call it an intertrochanteric fracture? Because here's the greater trochanter, here is the lesser trochanter, and the fracture is in between the greater and lesser trochanter, so it's intertrochanteric. Okay, so the surgeon has elected to use pins. So the pins will be, the pins are in position. The bone is in adequate reduction. It's not perfect. You can still see a little bit of alignment issue here, but it doesn't have to be perfect. And then the surgeon will just cut these pins and leave these in, and they'll stay in permanently. So again, some of the devices, these are the pins that you just saw. This is the plate and screws. This is a half of a hip replacement. So the patient's acetabulum stays in, and the ball and socket is contained on one side, and the plastic of this fits in to the patient's own joint. You would not do this surgery if the patient had a lot of wear and tear in their own acetabulum from arthritis. This would not be the case you would do. Instead, you would do a total hip replacement, and the difference here is, here's the ball, but you're also replacing, you're actually drilling out, you're scraping down. We have these big things, they look like a mushroom, and they come in different sizes, and you put it on the end of a drill, and it's got little holes and sharp edges around the holes, and it rotates, and as it rotates, it eats away, it bites away at the bone and the cartilage that's diseased, until you get a nice smooth surface that you can now put the cup up against. So the cup would be fixed on the acetabulum side, and usually we would put 1 or 2 little screws there. The screws would be sunken so that the screw head doesn't come up above the edge of the cup. Otherwise, it would rub against the other components, and that's how you do the surgery. Also, you drill out the femur, so you remove the cancellous bone, and then you put your stem down into the bone, and you can choose to either what we call press fit, meaning that it's a snug fit, it's measured precisely, it's got a very, like a pebbled surface to it, and the patient's bone grows into the prosthesis and makes it secure, or you can just cement it, in which case it's secure right from the moment that you finish the surgery. Both of these patients, whether you do the press fit or the cementing, those patients can be gotten up and ambulating and weight bearing immediately. So the workup for the hip fracture patient must include medical clearance, because all of these patients are going to be old, and you need to make sure that you don't lose sight of their other medical conditions and or any contraindications to surgery. So an important thing is a lot of these patients are on Coumadin, atrial fibrillation or whatever, TIAs, they're on Coumadin. You can't operate when the Coumadin is working. You'll have way too much bleeding. So you have to reverse the Coumadin. You can treat the patient with some shorter acting, low molecular weight heparin like Lovenox, and just basically have the patient clotting normally during the window of surgery. You can put them back on the Lovenox post-op and then start their Coumadin up right away. And as soon as their INR gets back to a therapeutic level, you can stop the Lovenox. But do they have heart disease? If a patient has a history of 3 MIs, you don't want them to have their 4th one on the table. Sometimes demented, bedridden patients who have stable fractures are best managed without surgery. If they're bedridden, they're not going to get up, they're not going to be weight bearing. If they're probably already quite debilitated, They're probably not in the best of medical shape. They may be in the last months of their lives. They may have fallen out of bed because they're confused and they got up out of bed and fell. And again, if you do the surgery, you might just be sort of pushing them to their demise a little bit quicker. So under those situations, even though almost all fractures of the hip are surgically repaired, in this case it might be better to just stabilize the patient, and I mean stabilize them as a result of their fracture, send them back to the nursing home and don't bother to do the surgery. So the standard of care is to try to get the surgery done as quickly as possible. Again, you can't mobilize the patient while the fracture has not been stabilized. So the quicker you can get the patient to the operating room, the quicker you can get them up and moving around. Once you have your hardware in there, you can immediately start getting the patient up and out of bed. Even if it's just to take 2 steps from the bed to a chair with assistance, that's better than just lying in the bed. Old people, again, get problems with pressure sores, you get problems with urinary tract infections, they can't get out of bed, so you put a Foley catheter into them, they get an infection from that. So it's just a cascade of events that usually can, or in many cases, does not have a good outcome. And again, the percutaneous pinning is where you don't have to make a big incision, you don't have to cut through the muscle, you just basically put the pin right through with a small incision. And of course, those are done under fluoroscopic control. You're actually guiding the pin, and you wear a lead apron. You know, everybody in the OR wears a lead apron. As you drive the pin in, you take spot X-rays just to make sure that the angle that you're driving the pin in is the right angle. A couple of shots while you're driving the pin in, and then a final shot when you have the pin in position. And then when you do the second pin, you do the same thing. And then a final X-ray to show, in other words, not just what you're seeing on the screen, which is the fluoroscopy, but you get an X-ray of the final shot, so you have documentation that the pin is where you wanted it to be. And again, if the patient has bad osteoarthritis, as I said, they're going to need a hip replacement. Post-op care, early mobilization with partial weight bearing. PWB means partial weight bearing. FWB means full weight bearing. Basically, partial weight bearing, here's the thing that you have to understand about partial weight bearing. Many patients think, well, non-weight bearing, which of course would be NWB. Non-weight bearing is when you basically have the patient with no weight on the limb, and the patient would need 2 crutches to non-weight bear, because when they take a step where they would normally put their weight on the bad leg, basically what happens is they switch their weight to the crutches, and that's how they manage to maneuver themselves. So naturally patients think, well, if full weight bearing is 2 crutches, partial weight bearing is 1 crutch or a cane. The fact of the matter is you cannot partially weight bear on 1 crutch or a cane. Partially weight bear means that you're going to not put your full weight on the affected leg. Well, think about it for a second. When you walk, you don't have both your legs on the ground at the same time. You're always taking a step, and at some point, you're putting your full weight on each leg individually. So if you're doing that, if you're trying to partially weight bear, at some point you're going to have to put your full weight on that partial weight-bearing leg. If you only have 1 crutch or just a cane and you attempt to shift your weight to that 1 crutch or a cane, what's going to happen is, in the case of a crutch, you're just going to spin around and fall. In the case of a cane, you're going to fall even quicker. So in order to partially weight bear, you really need 2 crutches. The difference is you now can sort of control the amount of weight you put on that bad leg. So you put a little bit of weight on that bad leg, and you transfer the rest of your weight to your arms through your crutches, and that's how you partially weight bear. I could, well, I don't know if I could do it. I don't have a lot of practice. But if you're well practiced, I could put a bunch of raw eggs on the floor, and I could have somebody partially weight bear putting their shoe on those eggs and not breaking them, because they transfer their weight to their crutches and their foot is only just literally touching the ground, giving them a little bit of stability. Or you can put 80% of your weight on the leg and just transfer the other 20%. But you can dial in what you want to do, as it were. I say dial in, but you can determine how much weight you want to transfer, yes.
How much movement are we talking about in order to mobilize them?
You mean as far as motion in the hip?
Well, no, I guess I mean just getting them out of bed, you say, to make sure to avoid infection and sores.
Right.
Just how much each day? Is it just like a...
Well, the first day you might do what we call, a bed-to-chair transfer. So in other words, the patient is gotten from the lying position to the seated position. There's a chair very close by. There'll be probably one and maybe two people. Then they'll stand the patient up, and the patient will put their weight on their legs. And they might take one step towards the chair, and then the assists pivot the patient and slowly put the patient into the chair. I know it doesn't sound like much, but that is much superior to keeping that same patient just lying in the bed for that 24-hour period. So even a transfer from bed to chair is better than nothing. For one thing, the patient is now sitting. They're sort of putting their weight in different places, not the same places that they would be if they were lying in bed. Their leg is bent, and they had a little bit of movement to get there, and it just psychologically puts them in a frame of mind where they say, guess what? I can stand up. I can do that. So the next day, maybe you have them walk to the bathroom. It's in the room, but now they're taking, 15 or 20 steps to get to the bathroom. And then after that, you have them get up. Naturally, you have physical therapy involved, so the therapist and the nurse might be the ones getting the patient up out of bed. But the more you can get them up and moving, even if it's just a little bit initially, the better for the patient. Okay, so you want to check the CBC on the first day. You don't even need a CBC, really. An H&H would be enough, hemoglobin and hematocrit. And the rationale there is they've had blood loss from the fracture, and now you've compounded that with the surgery. So for 2 or 3 days after their surgery, you want to check their hematocrit and hemoglobin, and then transfuse them as needed. We generally don't transfuse patients until their hematocrit gets down to around 26. And even in some cases at 26, we don't transfuse if the patient is stable. I don't mean stable, if the patient is asymptomatic, okay? If not, we would transfuse them. So if they're, experiencing dizziness or lightheadedness, or they're getting a little confused, we would transfuse them and get their RBC count up. And we would not give them whole blood, we would give them packed cells. Just an aside, if you see a hemoglobin and you multiply the hemoglobin by 3, that should give you an approximation of the hematocrit. So a patient with a hemoglobin of 15 will have a crit of about 45, give or take. A patient with a hematocrit, with a hemoglobin of 10 will have a hematocrit of about 30. So again, just a little thing. If you see a hemoglobin of 15 and a hematocrit of 27, there's probably a lab error because that just doesn't compute, okay? Remember also that sometimes it's not until the second or third day that you get equilibration. In other words, what may happen is the patient has some blood loss. They're in the hospital now. You're giving them IV fluids. When they lose blood, they lose cells and they lose plasma. You're replacing the fluid component, but not the red cell component. So sometimes the crit will drop down on the second or third day to the maximal point of its low point. So at the time of the accident, you got their crit and it was 34. The day after surgery, their crit is 30. And then 2 days after the surgery, their crit is 27. Again, you're seeing that dilutional effect of giving them fluid but not giving them the red cells. If a patient has a low crit but we're not going to transfuse them, we start them on iron. But it will take 30 days for the iron to get their crit back up to their preoperative point. And if you start a patient on iron, it can cause constipation, so give them a stool softener and take note of that. You want to continue to monitor their medical conditions closely. If they're diabetic, if they're insulin dependent, or even if they're on a hypoglycemic oral agent, you may have to put the patient on a sliding scale of insulin. This would be a very conservative insulin dosage. Remember, I'd rather have a patient with a blood sugar of 140 than a patient with a blood sugar of 40. So the 140 is not going to cause me any great problems. The 40, I'm going to have a comatose patient. So it's a conservative treatment. I might not even give the patient a dose of insulin until the blood sugar was maybe 180 or 200, and then I might only give 5 units. But it would be a sliding scale. So as the sugar is higher, the nurse would be instructed to give a bigger dose of insulin. And then if it gets over a certain point, I would tell the nurse to call me. Again, just to keep their blood sugars in check, but not to over-treat them. Remember that if they're not taking PO, you don't want to over-treat their blood sugars, okay? Once the patient is taking PO, you can put them back on their metformin or whatever they're taking, and then you can just monitor their blood sugars without the insulin sliding scale. If a patient has a history of bad heart problems, you might want to get a post-op EKG just to make sure nothing has happened. We use some anticoagulant to prevent a DVT. We're going to get therapy involved quickly. In most of these patients, I would say 80% of these patients are going to wind up in a rehab facility, at least for a short time, until they're able to do their ADLs. ADLs, of course, stand for activities of daily living. Their living situation will dictate this too. If they have a spouse at home or they live with a child, an adult child, they may be able to go home to the home environment much more quickly. If they're on their own, then they have to be functioning at a higher level to be able to tolerate the home environment. Some patients do permanently lose one level of function. What do I mean by that? A patient who may have been walking just fine may have to resort to the rest of their life with a cane. A patient who was using a cane now may need a walker. So that's what I mean by one level of function. It doesn't happen to all of them. I'm just saying it can happen. And if it does happen, it doesn't necessarily mean you, meaning the team that took care of them, did anything wrong. It's just the nature of the beast. Let's take a break for 5 minutes. My clock here says 5 after. I'm going to resume at 10 a.m.
I'm trying to remember the actual
It's called a hemiarthroplasty. It's a hemiarthroplasty.
Okay.
I don't know what an OBC is.
I hear infections from nodes, but these
But it's a hemiarthroplasty.
Okay.
It means because you have two components, two halves. One half is the cup, one half is the ball with the stem. So if you're just going to replace the ball and the stem, that's a hemi. Right. Well, not so much. It's not so much the nature of the fracture that makes it the most complicated. It's the nature of the surgery. So if you just get a pinning, percutaneous pinning is the simplest surgery, the least complicated. If you have to get a hip replacement, that's going to be the most. Well, and it's you can have a femoral neck fracture that you can treat with just a pin, and you can have a femoral neck fracture that you have to do with.
So each one of them.
Right. Right. In other words, that's right. That's right. One thing I will say most likely is even there, sometimes you can have an intertrochanteric tear fracture that becomes a pin. In fact, I showed the picture of it. More often than not, you need a plate and screw. The level of the surgery is really driven by, I would put it at 3 different levels. Level 1 is the pins. That's the simplest. Level 2 would be the plate. Level 3 would be either a half of a hip replacement or a total hip replacement. Yeah.
Something more for this customer on Friday. Can we just you're going over this photo here.
Well, I would think that it probably means symmetrical in the same joint, but again, if you have joint space loss in an area, let's say you have joint space loss here, the patient may come to you and be completely asymptomatic, and the reason is because it's not the weight-bearing part of the joint. Who knows why that wore out a little bit?
You guys think that's a big difference between RA and OA?
Well, RA isn't necessarily bone disease. RA is a disease of soft tissue. So patients with rheumatoid arthritis get really bad synovitis. That's what causes their pain. Now, over time, because they have chronic effusions in the joint, because there's synovitis over time will cause problems, those patients eventually can have a joint that collapses. But it's not the same mechanism as the osteoarthritic patient. Osteoarthritic patient is completely unmechanical for them. Where the joint collapses, you need it replaced. The RA, it's a systemic phenomenon. It usually involves more than one joint, and the joint space collapsing is a complication of the original problem of the rheumatoid arthritis.
Okay. All right. Thank you.
But, we don't talk so much about symmetry here from joint to joint because it doesn't really matter. I mean, you're only going to treat one. You're going to treat the joint that's the worst.
Put down like I was looking at him and looking at the joint space. I didn't know if it was that like it's losing the same amount of space.
Well, if he's talking about an X-ray of the hands, he might be talking about comparison, or comparing one finger with the other fingers on the same hand. But if I was looking at an X-ray like this and somebody talked to me about symmetrical joint space loss, particularly if if this joint is okay, I would probably be saying, well, the joint space loss here, and that's when more often than not you'll see the bad joint space. Same as the joint space. And again, this is the weight-bearing part of the joint. This is where I would expect to see asymmetry. Because many times joints don't wear out asymmetry. The knee is a perfect example. We'll talk about that when we get to it. But people will get either a varus deformity. So if this is my right knee, a varus deformity of the knee, which causes bow-leggedness, will do this. This is the side that's going to wear out because all my weight is on this. This side actually gets distracted. So this side becomes pristine. It's like that. It's beautiful. Yeah. Now that would be asymmetrical joint space loss in the same joint. The medial compartment is worn out. The lateral compartment is totally pristine.
Great, thank you.
Mm-hmm.
Yeah, she did team B, but like when she kind of messed it. So it was kind of long for us to like figure out who's winning and not. But once that happened, we took going this way. It was really it's like the never-ending bingo game. But honestly, I like.
Okay, I'm going to get started again. Okay. All right. Okay, so hip dislocations are much less common as an injury. The fractures are much more commonly seen. The hip dislocations much less commonly seen. I'm not going to talk about dislocations. It really does go beyond the scope of this lecture, except in the case of hip dislocations that come about as a result following a total hip replacement. This is a much more common problem. Oftentimes it occurs because the hip wasn't properly sized. When you do a knee replacement, you never affect the leg length, because it turns out that the amount of bone that you take out is equal to the prosthesis that you put in, and invariably the patient's leg length is the same post total knee replacement than it's the same as it was pre. However, in hip dislocations, you can actually affect the leg length. And it has to do with the spacer that you use. In other words, you put in a metal component into the acetabulum, and then you're going to put a plastic spacer, polyethylene spacer that goes into that metal component. And then the ball from the femoral component is going to fit into that plastic spacer. So the fit is going to be a snug fit. And depending on how thick that spacer is, you can affect the length of the leg. So it's important during the surgery that you check the leg length and make sure that the patient's legs are equal. Despite your best efforts, the leg length may not be equal or the sizing may not be precise. There are a lot more ways for a surgeon to mess up a hip replacement than there is a knee replacement. I will tell you that when you do a hip replacement, or even, well, less so with a knee replacement, but when you do a hip replacement, even with an experienced surgeon, there's always a representative from the company that made that prosthesis who's usually in the operating room. They're not scrubbed. They will take part in the surgery. They're not qualified to do that, but they're experts on the components, and they often have suggestions of what things to use to get your patient properly fitted. And even experienced surgeons will have that representative in the operating room with them. Oftentimes the representatives are fairly regional, so you get to know the rep pretty well over time. So pelvic fractures, again, occur in the elderly, mostly osteoporotic females, and they can either be stable or unstable. Stable fractures may require just a day or so of bed rest, followed by weight bearing as tolerated. And unstable fractures are often accompanied by other injuries, so soft tissue injuries. After all, the pelvis is in the abdominal cavity, and there's often major surgery required to take care of those problems. And the pelvic fracture becomes of secondary importance and is done more as a reconstructive procedure, or if the patient survives their soft tissue injuries, then you do a reconstructive procedure where you basically put the pelvis back together. Avascular necrosis of the hip is also noted as aseptic necrosis of the hip. And it basically occurs when you cut off the blood supply to the head of the femur, and as a result, the bone collapses. This will often occur in patients who are between the ages of 20 and 40, more common in males. We see more of this nowadays because of steroid use in sports and athletes. Great guy who was a player in both baseball and football and was really a good player in both, named Bo Jackson, was using steroids back in a time when they weren't really checking for steroid use, and this guy would hit 500-foot home runs, and then he would go into football when the baseball season ended and lead the league in rushing. Incredible athlete, but he did use steroids. As a result of that, he wound up with a rather incidental injury. I was watching TV when it happened. He was just being forced out of bounds. He kind of stepped wrong on his leg, and fractured his hip. and it wound up that he wound up with a hip replacement because he had avascular necrosis. That's why he got the hip fracture. He wound up with a hip replacement, and believe it or not, he actually thought he could come back and play baseball with a hip replacement, even though his doctors told him he was crazy. And he did come back to play baseball and lasted a couple of games, and that was it. You can't play a high demand sport at that level on a joint replacement. You can't do it. Not even Bo Jackson could do it. But Bo was an incredible athlete, and unfortunately, he would have been better off if he would have just picked one sport or the other. I once saw him in frustration after striking out break a baseball bat over his thigh. Of course, it was a thin-handled bat. I don't care how thin that handle is. You try to break a baseball bat over your thigh. He just basically went like this. It was broken. So I said, no, I don't think I'm going to try that. So, but the things that will increase your risk of avascular necrosis is alcoholism, steroid use, gout, kidney disease, and also sickle cell anemia, because obviously the vessel gets cut off with the sickle cells and results in avascular necrosis. So initially, in the earliest stages, these patients are asymptomatic. So you don't even know the process is going on. Later on, they may present with groin or anterior thigh pain. Sometimes they'll have some knee pain with it, or they may just present like Bo Jackson did with a fracture. Not to say he wasn't having some hip pain. He might have been, but he wasn't telling anybody about it, or he was using analgesics, don't know. But in any event, the patient may at some point develop more severe pain, and at that point seeks out some medical attention. And again, always be aware of the correlation of knee and hip problems. So avascular necrosis of the hip, on physical exam, you find an antalgic gait. Remember, the word antalgic means a limp due to pain. So there's not a functional problem here, it's just a pain issue. They'll have decreased range of motion with pain. And the natural history of this disorder will be for it to develop osteoarthritis, and eventually the joints, the femoral head will collapse. You can sometimes see it on an X-ray, and what you see is an area of low density in the bone. So you see what, could almost look like a cyst, and it just represents the bone infarcting or dying. The MRI is quite sensitive and will pick it up fairly easily. If you catch it early, before the collapse, restricted weight bearing and activity modification can help, but the long-term prognosis, regardless of whether you give the patient relief at this point, is that all of these patients will go on to develop severe pain, osteoarthritis, and will require a total hip replacement. Now we talk about arthroplasty. The word arthroplasty means basically joint, sort of making a new joint or replacing a joint. So we talk about hemiarthroplasty, which is the half a hip replacement that we talked about with the hip fractures, or total arthroplasty, which means you do both sides of the joint and you do a complete joint replacement. So again, most of the time, patients are going to present with a hip problem with pain in the groin radiating down the anterior thigh, and it can go as far as the knee. The pain will often be worse with activity and relieved by rest. If the patients are complaining about pain at rest, there's usually an inflammatory component. So here's the difference between the patient who has arthritis in their knee and the patient who has a torn meniscus. The osteoarthritis is not an inflammatory process, okay? It's a mechanical wearing out of the joint, but there's no inflammatory response. A meniscal tear will result in an inflammatory response. The knee gets swollen, painful, maybe warm to the touch. So the patient who has osteoarthritis, when you ask them about pain at night, will tell you, I don't have any pain at night. I go to bed and I sleep through the night, I'm just fine. The patient with a torn meniscus will tell you, I do have pain at night. So the resting pain becomes a hallmark of the inflammatory component. And oftentimes the patients with knee pain at night who have an injury often turn out to have a meniscal tear. Oftentimes they will tell you that they are uncomfortable if they lie on their side and their knees touch. Or you can ask if they sleep with a pillow between their knees. If they're a dedicated side sleeper, they're looking for a way to sleep on their side, and wherever they put their knee, when it touches the other leg, it hurts. So a lot of times they just stick a pillow between their knees, sleep on their side, and they're fine. But if you ask that question, and I can tell you I've astounded a few patients just by saying to them in the middle of all my evaluation, I said, "Do you sleep with a pillow between your knees?" They go, "What? Are you in my bedroom at night? What's going on?" And I say, "Well, it hurts when your knees touch, right, when you're sleeping?" "Yes, it does hurt when my knees touch." Oh, God, this guy is so smart. Not really that smart. I just happen to know that that's a common complaint of people who have a meniscal tear. So if you have a meniscal tear, I'm going to ask that question. So again, that's not a bad question to ask a patient with who you suspect has a torn meniscus. Now, you will find patients with torn menisci that will tell you, no problem when my knees touch. Okay, so it's not pathognomonic of anything. It's just something that happens more often. Again, if you have a lateral meniscal tear and the lateral part of your knee, when your knees touch, the two medial sides are touching, no problem at all. So it's not pathognomonic. But again, the patients with the meniscal tear will tell you, yes, it hurts me with activity, but it even hurts me after I stop the activity. The patient with osteoarthritis will say it hurts me with activity, but once I stop, the pain usually goes away. It may take a few minutes, it may take an hour, but the pain usually goes away. When patients with osteoarthritis are talking about resting pain, they're at the end stage of their osteoarthritis and no doubt need a knee replacement, or any joint needs to be replaced at that point. Lower back problems can sometimes present with hip pain. Again, the nature of your questioning should try to isolate whether this pain is radicular in nature, in other words, coming from the back and the nerve roots in the back. So is there pain in the back? Sometimes patients have radiculopathy from the back and they have no back pain. They just complain of leg pain. But again, asking the patient where their pain is, show me your pain. The patient who takes their hand and rubs it all the way down their leg, in the back or the side of their leg to their knee, is more likely talking about radicular pain. The patient who takes their hand and starts in their groin and rubs down the front of their thigh may be talking about hip pain. Okay? So again, I always ask the patient to show me where their pain is. The way they use their hand and the way they move their hand will often help me. Like I said, in the shoulder, patients with rotator cuff problems or bursitis will often take their hand, open palm, put it on the top of their shoulder and say, "It hurts me here." And they'll rub up and down over their biceps and their triceps. And they won't go past their elbow. The patient who has degenerative joint disease of the AC joint will take one finger and put their finger right on the AC joint and say, "It hurts me right in this spot here." So again, asking the patient to show you where their pain is very helpful. Osteoarthritis is very common. Again, it's a mechanical problem. It's just a wear and tear, often comes with old age. But I will tell you, I've seen 90-year-old people that I did x-rays of their knees, and their joint space look fabulous. So there's probably some other things that go into the mix here as to why the knee, the articular cartilage in the knee breaks down. Certainly if there's a previous injury, if a patient had a fracture of the tibial plateau and their alignment of their tibia and their femur is put out of just a little bit out of alignment, it could set the stage for them to develop wear and tear in the knee, excessive wear and tear, and eventually it wears out. Even a torn meniscus can set the stage for a patient to develop osteoarthritis in the knee 15 or 20 years down the line. If you have a meniscal repair, instead of a meniscectomy, where part of the meniscus is removed, if you have the meniscal repair, then you may do just fine and have no problems. But the meniscus has a purpose in the joint, And when you remove a torn segment or a torn piece of the meniscus, you do compromise the joints to some degree. You don't have any choice, because if you leave the torn piece in there, the patient will get arthritis even sooner because that torn piece is flipped up, is not in the right position, and over time will wear the joint down. So once the patient tears a meniscus, the die is cast, and the only thing you can offer them is removing the torn piece if it has to be removed. Repair is always the best thing. We'll talk about that a little more when we move along here. But the bottom line is that the damage is done. You take out the piece that's torn. The patient can get back to full activities, but they could develop a problem. And again, could, not always, but could develop a problem 15, 20, 25 years down the line with some osteoarthritis. Osteoarthritis increases as people get older. By the age of 65, almost everyone has some degree of osteoarthritis. But the difference here is not everyone is symptomatic. So the bottom line is, we in orthopedics, we're treating the patient, not the x-ray. So if an x-ray looks awful, and I say to the patient, how's your knee feeling? And they said, it's not that bad. I get a little ache and pain here and there, but, nothing that I can't control with Tylenol occasionally. And if I walk too far, it hurts, but it's not really bothering me. I don't care what your x-ray looks like. That's not a knee that needs to be replaced. That's not a patient who's going to be happy going through a knee replacement because of what their complaint was. The patient that I want to do a knee replacement on is a patient who says, I can't live with this anymore. My knee is really hurting me. And those are the patients that on post-op day 2, when you ask them, is the pain you're having now better or worse than the pain you had before the surgery? And they say, oh, you kidding me? This is much better than what I had before the surgery. Now I can smile to myself because I say, this is going to be a good result. But the patient who says, no, my pain before surgery wasn't anywhere near as bad as this, now I'm thinking, oops, we should have maybe not done this case. Okay? So again, and there is a significant amount of post-op pain after a total joint replacement, as you might expect. But you should only do a joint replacement as a last resort and not do one simply because the x-ray looks bad. So it's important to talk to the patient and get their take on just how debilitating this problem is. And if it's not that debilitating, then don't bother with it, okay? So the terms osteoarthritis, or OA, and degenerative joint disease, or DJD, are used interchangeably. So if you see that a patient has DJD on a note, it is exactly the same thing as OA. Okay, the terms are interchangeable. So osteoarthritis of the hip, more common in men, if we look at men and women before the age of 45. Remember, again, avascular necrosis, more common in men. Once we get past the age of 55, it becomes more common in women because now the offending pathological process is osteoporosis, which is more common in women than men. 20 million Americans or more have some osteoarthritis, not just of the hip, but some osteoarthritis. That's a big number. It's a big number. And again, it's a huge cost to our society, both in disability, surgery, and hospitalizations. So again, why do people's joints wear out? Well, physical demands, genetic factors, trauma, anatomic abnormalities to joints or bones can predispose, and so does weight. So people who are carrying around more weight, it's just a simple fact of physics. If you're carrying around more weight, then you put more stress on your joints, and the result is the joint will wear out more quickly. So again, what do we see with a patient with osteoarthritis? We see a slow but progressive worsening of both pain, stiffness, and immobility. Progressive, okay? So the patient who presents to you and says, my knee hurt and it started yesterday and it's really hurting, is probably not got osteoarthritis, okay? The patient who comes to you and says, my knee hurts, and you say, well, when did this start? And they say, well, 6 months or a year ago, it started bothering me a little bit. It wasn't that bad. I took some Tylenol. It was okay. but now it's hurting me more, so I've come to see you. That's more consistent with osteoarthritis. The first patient might have had a torn cartilage because their knee pain came on suddenly. And when you get older, you can have torn cartilage even without a significant traumatic event. Because again, the cartilage in your knee, the articular cartilage gets rougher as you develop some osteoarthritis, and the meniscal cartilage dries out and becomes more brittle. And the combination of the two can result in a meniscal tear with a relatively minor trauma. So while a young person, if they came to me and they said, my knee hurts and I have no history of injuring it at all, I'm going to say to myself, this is not a meniscal tear. But a 50 or a 55-year-old who comes to me and says, my knee hurts, I have no history of trauma, I'm going to think that this still could possibly be a meniscal tear. So I want to know, when did your pain start? And prior to that, did you have any pain in your knee at all? Does the knee hurt you at night? Or does it only hurt you with activity? Again, that's where these questions come in to help me. And sometimes you'll discover that it was simply a matter of kneeling down or squatting down for one reason or another. I had to get something out of the bottom underneath the sink in the kitchen, and so I just squatted down to get it out, and I stood up, and that turns out to have been the injury. And the patient says, well, now that I think about it, yeah, I felt a little twinge, but it really wasn't anything bad. My knee really started hurting the next day. So a lot of times I'll say to the patient, have you kneeled or squatted in the last couple of days or just before the pain started? Sometimes it shakes up a memory and sometimes it doesn't. But the bottom line is it could be a meniscal tear, even if there's no trauma in an older person. Eventually, the joint is destroyed, and we stage osteoarthritis in a joint. Stage 4 would be the total wearing out of the joint. Stage 1 is there's some softening and these micro little fibrillations in the joint, and then stage 2 advances that a little more, and so does 3, until when you get to 3, you're starting to wear it out, and then stage 4, it's pretty much completely worn out. So again, softening, fibrillation, these fissurings or clefts, then thinning, and then exposure of the underlying subchondral bone. When we say the word subchondral bone, chondral means cartilage. So a chondrocyte is a cell that makes cartilage. So subchondral bone is bone that's below the cartilage. So again, how these patients will present, again, is we've kind of talked about this. So the one thing about osteoarthritis of the hip that you should be aware of is that patients will notoriously have difficulty getting up from a chair. So this is a question I tend to ask if I think that a patient has osteoarthritis of the hip. Do you have trouble getting out of a chair? And the lower the chair is, or the softer the chair is, the more problems they have. So a soft, big, soft, old-fashioned club chair with the big, armrests, and the patient sits in it and their butt winds up about 6 inches off the ground, those are going to be the hardest to get out of. Probably kitchen chairs are going to be easier, or any chair that has something that the patient can push off on would be easier as well. Okay? And getting in and out of the car is also problematic. They'll also have a lot of problems putting on their shoes, so you can ask them about that. And they may have problems if they live alone. They may not be able to wash their feet so well. So sometimes if you look at their feet, they're grimy, they're smelly, and it's not because they don't care about it. It's because they can't reach down or bend their leg enough to reach their feet and wash their feet effectively. They'll develop some stiffness of the hip joint and loss of motion. They'll have decreased range of motion on physical exam. Usually internal and external rotation will be most dramatically impaired. They'll have some tenderness over the groin, but you have to push hard. The joint is pretty far down. And if you just put your hands and sort of, kind of just push very gently on the groin, usually will not elicit the pain. It's a good idea to start gently, but if you don't get a response and you're expecting that the patient should have some tenderness, you gradually start to push a little more vigorously. As you move the joint around, you'll hear crepitus. Crepitus, or crepitance, as it's sometimes referred to, just means a crunchy, grinding noisy joint. Okay, so if you bend your elbow and it cracks, that's crepitus. Okay, when you're wearing out the joint, sometimes little bits of cartilage can break off into the joint and also cause this grinding, or the roughness of the surfaces makes this sort of grinding and crackling sound. Many times as patients lose motion, remember, if you can't move a part all the way, the range of motion is limited, the muscle that serves that joint is going to get weaker. So if I cannot bend my elbow all the way to here, if I can only bend my elbow to here, this elbow is going to get weaker because I'm limiting the motion and therefore limiting the work of my biceps. If I limit the work of my biceps, it's going to get weaker. If I don't have full motion in this arm, I'm going to even use this arm more to compensate for my lack of mobility of this arm, which is also going to contribute to the muscle getting weaker. So it's very common for muscles to get weak when people lose motion in a joint. The downside of that for the joint is your muscle is like a shock absorber for your joint, and there's no place that this is more of a situation than the knee. Your quadriceps muscle is the shock absorber for your knee. And the more motion you lose in the knee, the more you favor that knee and use the other knee, the weaker your quadriceps get. The weaker your quadriceps gets, the less of a shock absorber you have, and the more shock is transmitted or stress transmitted to the joint, which accelerates the process. So, if a patient has osteoarthritis, look for other clues like Heberden's nodes of the fingers or Bouchard's nodes. DIP for the Heberdens, PIP. DIP is distal interphalangeal joint, and the PIP is the proximal interphalangeal joint. And again, x-rays depend on the stage of the disease. So you may see no significant abnormality. You may see some roughness and sclerosing of the bone. Again, the bone is more dense, sclerosing. The joint space narrowing, that's one of the sure signs of osteoarthritis. And you start to get these bone spurs that we call osteophytes. And then eventually some of these osteophytes or just the cartilage can break off and get stuck in the joint. And it becomes a loose body or just debris in the joint, which also adds to the patient's pain, crepitus, and loss of motion. Eventually the bone will get subchondral cysts, these darkened areas underneath where the cartilage and bone meet. And eventually the complete collapse of the joint space. No lab tests here. Don't bother to get blood tests. There are no osteoarthritis levels or serum porcelain levels or any other test that you can do. Okay, don't bother. You're not going to get any information. The only thing that's helpful is an x-ray. In the case of the knee, we'll talk about weight-bearing, single-legged weight-bearing films. So in the early stages of osteoarthritis, what do? We direct it at pain relief or treatment, maintaining motion and strength, so giving the patient a home exercise program, patient education to avoid activities that accelerate the process. Particularly with osteoarthritis of the knee, I would often see people who are, those kind of runners that get their runner's high. They get that high that they get with running, and boy, let me tell you, you show them their x-ray and you say, you're killing your knee. Why don't you consider taking up biking? You can bike in the spring and the summer. You can have an exercise bike in the winter. You can still get your heart rate up. You can still get your exercise. You can keep your legs strong. You can do all those things. But the difference between the bike and running is when you run, every time you take a step, you put all your weight over one knee joint, the joint where your foot is down on the floor. And every time you take a step, you create a shock wave that goes from your foot up your leg. And that is going to be to some degree absorbed by your knee joint. So you're messing up your knee joint. If you get on a bike, the first thing you do is you put your butt on the seat. So all the weight is on the seat of the bike, and you're not putting your weight through your joint. It's a much more knee-friendly activity. But I'll tell you that, these people, you'll say to them, you're gonna wear this knee out in a year, and you're not going to be able to run for exercise once we do a joint replacement. You can't do it. And they still won't stop. I said, you can spare this knee and ride the bike, because when you have a knee replacement, you can still ride a bike, but you can't run. Patients will say to me, can I run on a knee replacement or a hip replacement? And what I usually tell them is, you're crossing the street, a truck is bearing down on you, run. But if you're asking me, can I run on this like a source of activity? Can I play basketball? Can I do those things? I'm going to tell you, no, you can't. It's not your natural joint. It's metal and plastic. It's not meant for you to run on. It's meant for you to do activities of daily living and walk on it without pain and with better mobility. That's what a total joint replacement is meant to do. Weight reduction, if it's applicable, will help the patient, and then judicious use of anti-inflammatories. As the disease progresses, symptoms will get worse. There'll be progression on the x-ray, and then the end point is when the patient tells you, I'm having resting pain. So pain at rest is an ominous sign and usually indicates that the patient is getting closer to a joint replacement. So the bottom line, what's the threshold for a joint replacement? When the patient can no longer tolerate the pain and loss of function, then the only viable treatment for them is a total hip replacement, assuming, of course, that all the other treatments that you've done are no longer successful. So steroid injections, viscous supplementation, various things that you can do, activity modification, exercise, all the things that you can do that you want to do for the patient with mild or moderate arthritis are no longer working, and the patient is no longer satisfied with the amount of pain they have and the loss of motion. Now you do the joint replacement. It's justified. It's justified at this point because there's no other alternative for the patient. And if you have a really old patient and they're losing their mobility, they're putting one foot in their grave if you don't do the joint replacement. Because once they lose their mobility, once they wind up in a nursing home and they lose their will to live, bad things happen. So if you have an older patient, and I've had patients come to me and say, I know I'm too old for a joint replacement. And my answer to that is, no, you're not. I don't care what your age is. If you're 70 years old and you've had 5 MIs and your heart is getting 1 cell of blood at a time, yes. I don't care what your age is, you're not going to get a knee replacement, okay? But if you're 95, and I say 95 because we've operated on a 95-year-old woman and did a total knee replacement. But she was in good health. She didn't have any medical problems. She was on no meds. No meds, 95. Distill that and give it to me. I'll take it. 95, no meds. She said, I know I'm too old to get a knee replacement. I said, no, you're not. You're not too old. You're 95 going on 65. And we did the knee replacement. She was very happy, and who knows? I mean, she might be 120 and still running around in Manchester for all I know. So anyway, you're never too old for a joint replacement. It's a case-by-case decision, and the issue is risk versus benefit. It's the same with everything we do in medicine. It's always a matter of risk versus benefit. Okay, so that's what osteoarthritis looks like without the redness. The bone doesn't actually get red. That's just the artist's way of showing inflammation, which, by the way, there isn't any inflammation. So I don't know what they're trying to show there. But you can see clearly the joint space has collapsed. Here, this is an osteophyte over here. This is an osteophyte over here. So this is an osteophyte over here too. So that's what osteophytes look like, little bone spurs. So this is an AP view of an osteoarthritic left hip. So what do we see? Very sclerotic bone, right? Very sclerotic bone up here. Less sclerotic, but still some sclerosis over here. But again, this is the weight-bearing surface. We don't see, if we look for the joint space, I can see a little bit of joint space where my arrow is here, a little bit of joint space up here, and now I lose it. I don't see any joint space up here. It's completely collapsed. This is an osteophyte. This is an osteophyte. This little thing here is an osteophyte. And you can even see that there's some distortion in the normal shape of the femoral head. This is an osteoarthritic joint that needs a total joint replacement. Okay? This is just another view. Again, you can see the joint space, although not quite as clearly. You can see osteophytes here, osteophyte there, osteophyte up there too, probably some osteophytes along here. And again, just a hip that's pretty much worn out. So another x-ray, again, you virtually see no joint space. Here's the femoral head, and it's right up against the acetabulum. And, again, maybe a sliver of joint space down here, but certainly nothing up here. These are probably some bone cysts. Not sure what that is, but that's probably some bone cysts up there. And again, that's an osteophyte there. This is probably an osteophyte down here. And so this joint is pretty much gone. So the patient is going to need medical clearance. This is not an emergency operation, except maybe in the patient with a hip fracture. So it's elective, so you've got plenty of time to work the patient up. We don't work the patient up in orthopedics, but we say to the medical doctors, we want clearance for this patient. Tell me that this patient is buffed up and ready to go for their surgery. So if they have hypertension, I want to know that their hypertension is well controlled. If it's not, adjust their meds and get it under better control. I know, okay, they had an MI 4 years ago, but how's their heart doing now? Can they take the stress of surgery? Do they need to see the cardiologist? Do they need to get a stress test? Any of that stuff should be done. Pre-op screening includes a complete or comprehensive medical metabolic profile. That includes lights, BUN, creatinine, glucose, liver function tests, and usually a lipid profile is included. We don't really care about the lipid profile. It's not going to influence our surgery, but it's nice to know that a patient maybe is on a statin if they have elevated cholesterol and triglycerides. A CBC with a diff, we want to be sure that the patient's hematocrit is good, they're not anemic, they have platelets, and we also want to be sure that they don't have any occult infection. PT-INR as a baseline, we want to be sure that the patient's blood is clotting the way it's supposed to. We're going to do a big operation. We want a PTT, a prothrombin time, partial thrombo time, something like that. Yeah, just order a PTT. They know what it is in the lab. But again, it's the flip side of the coin of the PT-INR. The PT is the pro time, and I believe the PTT was the partial thromboplasty time or something like that. But these are tests basically to see the status of the patient's blood clotting. And then we type and cross the patient for 2 units of packed red blood cells. They don't need whole blood. You don't want to give an old person with a heart that's already under the stress of surgery the additional intravascular volume of whole blood. So we just give them the packed cells. That's all they really need is the cellular components. We do it as a type and cross match, not a type and screen. A type and screen means the lab will do the blood work and tell you the blood typing and the serotypes and everything you need to know to transfuse the patient, but they will not get blood available for the patient. If you do the type and cross, then the American Red Cross, they not only do the lab work, but the American Red Cross will send however many units you type and cross the patient for, and we usually do 2 units. They will send the blood to the hospital, and the hospital will keep it in their blood bank. So the blood is available to you if and when you need it. And the blood will usually stay there for about 72 hours. And then after that, it gets released back to the blood bank, back to the American Red Cross to be reassigned, since blood is a scarce resource. And generally, we know by post-op day 1, or at the very latest post-op day 2, if we have to transfuse the patient. After that, if you have to transfuse the patient, you're going to have to type and cross them again. A urinalysis with a culture and sensitivity. Why do we get a culture and sensitivity? Because sometimes old people, particularly old ladies, can have an asymptomatic urinary tract infection. So What's one of the most common symptoms of a urinary tract infection? It's urinary frequency. Lots of times old ladies live with urinary frequency. So when they get it from a urinary tract infection, they don't know they have an infection. The urethra is not as long in a woman as it is in a man, so a lot of times the women don't get the burning. Men get burning when they urinate and they have a UTI. Women don't always get it. So a woman can have a totally asymptomatic UTI, but if they have a urinary tract infection and we do surgery on them, we're putting additional stress on their body. It could result in the patient developing a sepsis. And septicemia would not be a good thing post-op. Plus, if the septicemia gets into that joint we just put in, we got to take it out. There's no way you can treat a septic joint and leave the hardware in. You have to remove it. So that would be a disaster. So we do a UA and a CNS on our patients before we do total joint replacements. Cardiogram, of course, goes without saying. Chest x-rays, which we used to order routinely, now we only order if indicated. So if a patient has known pulmonary disease, I'll get a chest x-ray. Other than that, I don't bother. So it's a same-day admission for the patient. So generally what we do is we bring the patient into the office, and as the PA in the office, I worked up the patient pre-op. So I did a complete H&P, complete history and physical. I went over all their meds with the patient so that I knew exactly what I was going to order post-op. I reviewed with the patient using models, including a model that we had in the office of a hip replacement to show them what the surgery was going to be all about. Okay? And there are different makes and models, and surgeons have different preferences. So, just like some people like BMWs, and some people like Mercedes, and some people like Fords, and some people hate Fords, and it's the same way with these things. Surgeons have preferences. They like to use the same model all the time because it gives them that familiarity that makes them a better surgeon. So usually the surgeons will go with one model and stick with it. So they'll always use a Johnson & Johnson or J&J, or they'll always use a Dupuis or whatever. So that's the surgeon's choice. The prosthetic can be press-fit or cemented. Press-fit in the case of a person who is maybe a little younger and you think you might do a revision of the knee replacement. The reason you would press-fit it is because when you revise it and you remove the components to put in the new components, if it's press-fit, it's much easier to get out of the bone. If you cement it, you have to chip away at all that cement to get every last bit of cement out because you can't put new cement over old cement. It won't hold. So it's a lot less surgery. So if we have a 60-year-old patient with a joint replacement of a hip, we're definitely going to press fit it. That way, when they come back when they're 72 or 75 for a replacement of their original, it's a lot easier to get the components out and a lot less surgery. Older people, if you come and you're 80 or 75, we'll probably put in a cemented prosthesis because that's going to be the last one you're ever going to need anyway. So post-op day one, we get the patients up and out of bed. Okay, rapid mobilization again. All patients will get Coumadin or some sort of blood thinner for at least 6 weeks post-op. That's when the risk of DVT is the greatest. And the risk of DVT with a hip replacement is greater than the risk of DVT with a knee replacement. I don't know why that is, but it is. We use AV impulse boots and TED stockings. TED stockings are just an anti-embolus stocking. It's a very tight stocking. They come knee-high and thigh-high. We generally go with the thigh-high. We prefer those over the knee-highs, which we think are not as effective. Patients hate them, but when you tell them that the alternative is a DVT and a pulmonary embolus and they could die, they learn to live with it. I keep the TED stockings on at least for a month after surgery, so long after the patient has gone home. They're going to stay on that Coumadin for 6 weeks. Then WBAT means weight bearing as tolerated, particularly if it's a cemented prosthesis. Sometimes a press-fit prosthesis can have some micromotion. Micromotion means just what it says. It's such a small amount of motion you can't see it. You wouldn't be able to see it if you were able to look. You can't determine it on an x-ray. You just assume that that's what's causing the patient some pain, and the patient will tell you usually the pain is right in their proximal anterior thigh. That's where the press-fit prosthetic is. Hip precautions for 3 months. This means avoiding certain types of movements that can result in the patient's hip dislocating. When we do a hip replacement, remember, we're not just operating on bone. We have to open up. Open up the muscles and the ligaments to get at the joint, and then we sew those things back together. Initially, the sutured repair of those things is not as stable and sturdy as the original tissue was. So we have to respect those tissues while they're healing, and if patients move their hips in certain ways, the prosthetic can come around and put pressure on the ligaments, on the fascia, on the muscles, and the result is that pressure could cause our repair to open up. And once it opens up, that prosthesis can come out. It's not stabilized anymore. Usually if it comes out, you can get it back in, bring the patient just to the operating room for the fluoroscopy, and then you manipulate the leg and you can pop it back in, but invariably